Hello, InfectoCast crew. This is Klinger speaking,
And here is Laís.
and today we have a very special guest with us, Dr. Nancy Bellei, a professor at the Paulista School of Medicine. And for those who don't know, she's our guest from our very first episode, right? We're almost reaching episode number 200. I don't know if we've already passed it. And she was here in our very first episode talking about new pandemics. Thank you for being here, Professor.
It's a pleasure. Thank you very much.
And today we're going to talk about a very common respiratory virus, one that we're increasingly gaining a better understanding of, which is the metapneumovirus, right? Professor, in recent years, we've made a lot of progress in terms of our knowledge, right? With the popularization of molecular biology techniques, and metapneumovirus has become part of that context, hasn't it?
Yeah, it kind of came out of nowhere, didn't it? Because there was an outbreak in China and people started hearing about it. And people were very fearful of new viruses after what happened during the pandemic. And when I say people, I mean clinicians as well. Because since we didn't routinely diagnose metapneumovirus, suddenly you hear about a virus causing respiratory illness in China, and that's it. It's a new pandemic. Later, it became clear that it wasn't.
It was just post-pandemic.
Yeah, it was at the end of 2024, right? Which was more or less when most respiratory viruses managed to return to their seasonal impact, or not, after we came out of the pandemic period, right?
But even so, before the pandemic, we already had data on the mortality, right, from these viruses.
Yeah, the metapneumovirus is a virus that's very similar to the respiratory syncytial virus. Some virologists even believe that it has been circulating in the human population for about 400 years when it may have diverged from the respiratory syncytial virus, right? But in 2001, the group from the Netherlands, which is a very strong group in respiratory virology, identified it in samples from patients from the 1950s. So we know for sure that there was already data on the disease from 1950. And then in 2001, it became known. Then the pandemic came and the respiratory viruses disappeared. Then after 2023, the circulation of all respiratory viruses starts to settle back in. And then there's an outbreak at the end of 24 in China. And people are like, wow, what virus is this?
Is there going to be a new pandemic in Brazil too, right?
There was some concern, right? Even though it's already known, could it be an important mutation? We know that it has some subtypes, right? It has several genetic alterations, right? We have type A, type B, and among those 1 and 2. So it can have genetic changes, but it wasn't a new virus. It was a susceptible population that hadn't been exposed during the pandemic years. And in the winter, when other viruses are circulating, this ends up creating significant demand on the healthcare system. It draws attention, it gets media coverage, it caught the attention of the WHO, but it turned out to be the metapneumovirus.
And does the seasonality of the human metapneumovirus align with the typical annual seasons? Or is it more complex than that?
Yeah, there's something really interesting about that. We had 2 important studies here in Brazil during the 2009 H1N1 pandemic. One study from my group looked at who was being hospitalized during the H1N1 pandemic. Of course, most of those hospitalized had H1N1. The second most important virus, even among young adults, was metapneumovirus. And Professor Sonia Raboni from Paraná also conducted a study at the same time and found that the second most important virus was Meta. So we saw that it was a virus that circulated more at the end of July, August, and September, which is the end of winter and the beginning of spring. Later, several international studies came out in the Northern Hemisphere showing that you can detect any respiratory virus throughout the entire year, especially in large cities. But it has this preference for the end of winter and the beginning of spring. That is, after influenza starts to fade away and RSV is also leaving the scene, then it ends up coming in.
So it also follows the same pattern when we look at COVID and influenza. COVID? Is there any protective factor when another virus is present, or does it wait for these endemics?
Yeah, we've observed that there is a certain ecological niche. For example, you don't have major influenza epidemics occurring alongside COVID, even though COVID can circulate all year round. But you don't see it We've been observing this since 2023. We know that RSV and influenza, generally RSV starts first and influenza comes after. This year was a bit different, but they are able to co-circulate for a certain period. Metapneumovirus, since it has many similarities with RSV, we don't see it circulating at the same time. So it's possible that there is some ecological interference, and also with influenza. It's quite unlikely. But I'll say it again, if you look at the big cities, people travel, right? You have a population with many different age groups and a lot of people in every age group. So, of course, it's possible to detect it, but it's not the time when you'll see a rate of 20% of the population seeking healthcare services for metapneumovirus at a time when there's an influenza outbreak, for example, or RSV.
But it still continues to bring negative outcomes to this at-risk population like all respiratory viruses.
Yeah, you had asked me about the impact on mortality. So there are studies by Dr. Edward Walsh, who is from the United States, was with the CDC, who is an authority on RSV and respiratory viruses. And he presented at the last ESCMID, right, in Munich. He showed data on hospitalized adult patients with metapneumovirus. And when he compared those hospitalized with influenza, with COVID, with metapneumovirus, and with RSV, the mortality rates were very similar among the hospitalized adults, right? So it's striking 10% mortality among those hospitalized is a significant and high rate.
Exactly. And is it common for us to find either colonization or co-infection with other respiratory viruses?
Yeah, with rhinovirus. Rhinovirus is the companion of the vast majority, right? So we find rhinovirus all year round, and it's possible for us to detect co-infection. Asymptomatic infection is less common, right? Yeah, there are few studies, few papers on this. I imagine it's possible for us to find asymptomatic infection because we see it with respiratory syncytial virus, but not as frequently as we see with SARS-CoV-2, for example, where asymptomatic infection is much more common, right? And it's important to mention that at the extremes of age, it is very significant. It is the second most important cause of bronchiolitis in young children, right? And not so much in those under 6 months, but in those who are a little older and in the elderly population, especially those with comorbidities. And the immunocompromised, right? In immunocompromised patients, we've seen very significant outbreaks with high mortality because it facilitates bacterial pneumonia.
Exactly. Yes, including with extremely high mortality in those who receive hematopoietic stem cell transplants, especially in the first year, which is the most sensitive period. Professor, I'd also like to take this opportunity to mention that there was some confusion with the ITSA and the guideline from the society, the guideline they made for pneumonia. And they included as a universal recommendation the concomitant use of antibiotics for all viral infections. And then the IDIDA published a statement, right, complaining about this, saying they don't agree with or endorse that pneumonia guideline from the United States. So how does that work? Will metapneumovirus follow the same trend as influenza or not?
Look, studies show that, for example, with influenza, up to 30% of patients, depending on the patient group, of course, it's higher in the elderly, right? It's lower in young adults, much higher in very young children, and there is a bacterial complication on the 5th, 6th, or 7th day after an influenza infection. This has a microbiological basis. There are countless studies over decades showing that various mechanisms of the influenza virus facilitate pneumococcal adhesion. So that's clear, and the same goes for Staphylococcus. The same thing applies to respiratory syncytial virus. Now, it's not at the beginning of a viral illness that you're going to have a bacterial co-infection, and it doesn't always happen. So I'll say it clearly. I do not agree with the use of antibiotics just because a patient with a respiratory condition is at risk or is hospitalized. And we learned this with SARS-CoV-2. You saw
This
how many patients were hospitalized, and we started giving antibiotics because we didn't know the disease, and then stopped because we realized it was purely viral. SARS-CoV is less so, but metapneumovirus also facilitates respiratory infections, just like RSV or pneumococcus. So it's possible that after a few days with metapneumovirus, the person could even develop viral pneumonia, get better, and then later develop a case of bacterial pneumonia. That's when you assess and introduce antibiotics. But at first, remember that we have a microbiota, and nowadays we know, even in the lower respiratory tract, that you will alter it with antibiotics. So you could even cause a secondary complication from using antibiotics without a proper indication.
Exactly. And we see this movement trying to implement these diagnostic tests precisely as a measure to avoid the use of antimicrobials. And then they simply throw out this recommendation to start antibiotics for every viral infection, right? Which it goes against everything we've been trying to do.
Yeah, and we have to be very careful because sometimes a colleague orders a CT scan in the emergency department and runs a respiratory panel. The respiratory panel, which includes metapneumovirus, is not a rapid panel, right? It will take a few hours, plus the pre-analytical and post-analytical phases. So the colleague looks at the CT scan and sees an image on one side of the lung and says, wow, this is the start of a bacterial pneumonia. And then he prescribes antibiotics. If he does another CT scan 3 days later, he'll see it on both sides. And by then, the viral panel is back and he gave the antibiotic unnecessarily, right? So we need to remember that these viruses cause respiratory illness. Often you might just have a viral pneumonia.
And about the genetic part, well, yeah, the difference between it and the respiratory syncytial virus, because, for example, we managed to get a vaccine for RSV, but for metapneumovirus, it seems like everything is still stalled, right?
I think your question is very important because since they are closely related, they're from the same family, Pneumovirinae. And as I mentioned at the beginning, probably way back, RSV was an ancestor. They cause very similar diseases in children, like bronchiolitis and viral pneumonia. Some people think it's possible that the vaccine or monoclonal antibody for RSV could protect against metapneumovirus. It does not protect, even though they have a similar viral structure, and they both have the F protein, which is what we use for the monoclonal antibody and the vaccine. They are different in their genetic sequencing, so there is no protection. On the other hand, there are already vaccines in phase 2 and one in phase 3, either mRNA or virus-like particle vaccines, which are combined vaccines for RSV and metapneumovirus, targeting either the pediatric population or the elderly. Eventually, viral particle vaccines could also be interesting for immunosuppressed individuals, right? Depending on the group, etc. Because this is a group that is greatly affected by these two viruses.
Perfect. And Professor, the development of mRNA platforms speeds up this process because people often question this, right? They ask, how did so many vaccines suddenly appear, right? Plus, there's the reuse of these platforms.
Yes, the mRNA platform has been known for decades before the emergence of the COVID-19 pandemic, right? In fact, it was already being established for other viral emergencies. So the platform itself, its safety is very well known. And after we used it and saw its efficacy, safety, and everything else, now there are several platforms for influenza. Influenza combined with COVID, for other respiratory agents, and even for the one I mentioned, which is for respiratory syncytial virus with metapneumovirus. And these two viruses, although they can mutate, are much more stable than SARS-CoV and influenza. So when we have a vaccine, it probably won't need frequent reformulations, which sometimes even makes the public lose trust because they say, wow, but every year the vaccine has to change, right? Yeah, for these viruses will probably have significant stability.
Perfect. Professor, the use of ribavirin in cases of metapneumovirus, right? Some people end up using it off-label, but what evidence do we have regarding ribavirin?
So
Ribavirin is an antiviral drug,
the hallmark of viral respiratory diseases.
the Anna Hickman of infectious diseases, right?
It's
Everywhere.
It's everywhere. Yeah, actually, ribavirin had its role in hepatitis, right? Ribavirin was used and still is for some groups that treat patients with stem cell transplants. In vitro, it has antiviral action against several viruses, not just respiratory viruses, but in practice, for example. Decades of study and attempts to use it with influenza have shown no impact. For respiratory syncytial virus, we always look for randomized controlled studies. So there is only one study with inhaled ribavirin, which compared it to the use of immunoglobulin. Ribavirin, as compared to receiving no treatment in the different groups, showed that it did reduce mortality somewhat. This study was not reproduced, so in very severe patients, and the most severe are immunocompromised, such as stem cell recipients. Some groups have used it, including in oral form, but when you look for randomized controlled studies, especially because it has many side effects. So that's for respiratory syncytial virus. For metapneumovirus, there is no evidence that it works. And we have to remember that viral respiratory illness, in the vast majority of people, resolves on its own, spontaneously, without the need for treatment. So it's very difficult in those patients where you consider treatment who are high-risk individuals or those with comorbidities, which are extremely heterogeneous groups, often dealing with complicated immunity, to set up control groups and to be able to assess not just mortality. Sometimes mortality is related to the underlying disease and not to the virus itself. To relate viral load, symptoms, and bacterial complications. So as of now, the evidence does not support the use of ribavirin, neither inhaled nor oral. And remember that it is teratogenic and has a significant impact on altering the red blood cell count. So we have to understand that some groups use it in this situation, but from the point of view of an additional resource.
Yeah, and we also see the difficulty, right, in establishing these studies regarding the timing of symptoms, right? For viral infection, that's fundamental, right? And, establishing when the patient will start treatment with the possibility of viral load clearance at that specific moment, because that will really depend on when they arrive at the service, right?
Yeah.
So it becomes even harder to have large, robust studies on this.
Yeah, it's very difficult. And you touched on an important point because measuring viral load in viral respiratory disease is done in the upper respiratory tract. That's different from hepatitis C or HIV, where we can properly quantify it in the blood. So we have significant variations, and there are even studies from your group showing that depending on who collects the sample, you can get a different viral load in the same patient at that same moment. Second point is that what happens in the lower respiratory tract sometimes doesn't correspond to what's happening in the upper tract. So, for example, in 2009, during the H1N1 pandemic, sometimes patients had a negative swab but were intubated with pneumonia, and the lavage was positive for H1N1. Was it not worth giving an antiviral to this patient? Nobody knows. I wouldn't prescribe it based only on the upper respiratory tract. So sometimes we don't know what's happening in the other compartment. It's really hard to do a study like that, right?
Exactly. And we end up having to manage the risk, right? After all, respiratory viruses are going to affect everyone and are often self-limiting, but we need to pay closer attention to those priority groups who are at higher risk of negative outcomes, right? So it's also a disease that's quite peculiar in that way.
Yeah, and we're learning more and more that one of the most important groups at risk of decompensation are patients with cardiovascular disease, because everyone tends to think, well, it must be asthmatics, people with COPD, emphysema, or cystic fibrosis. Clearly, these patients do have complications with respiratory viruses, but patients with cardiovascular disease experience secondary complications, and there is data showing higher mortality rates, especially in the group with congestive heart failure. In Brazil, we have a large number of people who sometimes don't even know they have heart failure because we have a hypertensive population, and we know about the ventricular overload caused by years of hypertension. We also have Chagas disease and other conditions that lead to heart failure.
Exactly. And then a patient who already has a low ejection fraction, who is going to get infected, who will have an inflammatory response and overload. These are patients who are already very borderline. Even the slightest modification, right, in the regular daily routine, right, in the homeostasis of this patient can very easily trigger a decompensation that will lead to hospitalization and other serious complications.
Yeah, something you mentioned is that any intervention, right? And remember that, for example, Metapneumovirus, just like RSV, they have a symptomatic characteristic, which is bronchospasm, right? These are viruses that cause a lot of bronchospasm. So what do you do when someone has, bronchospasm? You're going to use some drugs, right? Anti-inflammatories and bronchodilators. For someone with ventricular overload, you're going to make their condition worse. So even when you're treating the respiratory symptom, you end up adding more events, interventions that will decrease the myocardial response, right? So this is a very important point because sometimes the clinician focuses a lot on the patient with lung disease and forgets about the one with heart disease. Even rhinovirus can destabilize a cardiac patient, right?
Exactly. Yeah, so I think that's it. Do you want to present anything else?
No, I have some anxiety about metapneumovirus because that's the thing. We still don't have a vaccine, we don't have a treatment, and it's just as severe as influenza or RSV. And our concern about influenza B.
Yeah, to wrap up, I'm really curious now that we have in Brazil the vaccine for pregnant women, and there was a really high uptake,
Huge.
right? We're very pleased about that. So hospitalizations due to respiratory syncytial virus will decrease. We have the vaccine for the elderly and also for at-risk populations. Both vaccines are approved for individuals over 18 years old. So if the population adheres, what will happen? Will this niche change and will we start testing more and finding more metapneumo? I'm curious to see that.
Yep.
Exactly. Because, exactly, right? The ecological niche exists, right? It will inevitably be occupied by someone, right?
By someone.
So that's it, Professor. Thank you very much.
For being here.
Very enlightening. And we have several other viruses, right? For us to discuss and talk about. See you next time.
Goodbye, everyone, and have a great day.
Mm-hmm.